About 3 hours ago, I was in a living room talking with an exhausted caregiver. He's taking care of not only his wife, who's got dementia, heart failure, now diagnosed with cancer, and he's taking care of mom in her 90s with dementia, heart failure, diabetes. And I was in the living room and he just looked utterly wiped out. And because of her cancer, she's having increasing needs, increasing symptoms. How do we manage her symptoms of weakness and having more shortness of breath? How do you tackle that? How do we as a team help this poor caregiver who is really struggling to take care of wife and mom? The story is exactly, I'm gonna, this journey, the next hour or so, it really highlights what can we do to help these patients at home with these complex needs, with increasing need of symptom management and supporting the caregiver. How can we do it well? And you'll see it on later slides. It's about envisioning this full service model of care, okay? So let's start by talking about what is home-based primary care and how does it help patients with serious illness. It's a model of care that brings providers with modern technology into the living room to improve the quality of life of the patients and, of course, their caregivers, just like I showed you in a real-life case from 3 hours ago. We want to give them great care. We want to keep them at home, keep them out of the hospital and the nursing home and the emergency room. They don't want to go there. And we're going to do our best to keep them at home. And with all of that, we can really reduce the cost of medical care without compromising on quality. The quadruple aim is an expansion of the triple aim that talked about better outcome, improving patient experience, lowering the cost of care, and also improving job satisfaction for provider and staff. Because over the past year or two, with the COVID, with the Great Resignation and the hiring challenges, you've all heard this, the burnout and so on. It used to be said, what, no money, no mission? Now you can say, no staff, no mission. And we know, and I've lived this, and I talk with other practices locally and around the country, home-based medical care is an outstanding way for providers to have that sense of fulfillment. They're more than just data entry person at a laptop. You really have the opportunity to engage and talk and be in the moment, be in the experience with your patients and their loved ones. So is home-based primary care like one block? I'm with Northwestern. Is that the only model? Well, you know the answer. It's not. I'm part of an academic medical center, but there are multiple other ways that home-based primary care can exist, from a community hospital, independent group practices, and I know they're out there today. VA operates a very robust and a long-standing house call program. They can be an extension of a hospice and palliative care organization, which we can talk more about today, and also, as Melissa said, in the additional series that are to come. And also, as we get into value-based care, they are also looking for ways to maintain quality while reducing cost. So what are some of the clinical application or clinical models of home-based care? What I do is the second one, is the well, I shouldn't say that. I do a little bit of both. We do longitudinal care. We provide oversight. Most of my patients are 65 and older. Actually, we ran a study. I'm sure it will probably resonate with you. From our internal data, we're about 82 and a half years of age, and predominantly women, about 66% versus the rest men, okay? But there are different models. There are other models out there that provides transitional care, short term. I won't name any names, but they come in, for example, could be a post-hospital discharge patient where they come in and they do a transitional post-hospital tuck-in visits. It may be one, it may be several, to make sure that they're stable. And they often target those patients with multiple diagnoses and high readmission risks. Again, working backwards, this is pretty much what I do. Those with advanced illnesses, chronic conditions, and so forth. And they can take a lot of time in a PCP's office. We often talk about having an elevator speech, and James has talked about it in his writings and so forth. Having that speech that talks about the value that you bring, whether it's for fee-for-service, whether it's under value-based care, whether you're talking to a care coordinator or the C-suite. You know, access is an issue. We all know that. I can help decompress the PCP's office with these high-need, high-cost patients so that you have more openings to see the less complicated patients, therefore improving access. So that could be a talking point for you. So that's what I do. And then the other, as you can see there, is again, it's about the transitional care, trying to reduce readmissions, those at high risk of readmissions. So why the interest in home-based care? What are the drivers behind this? Dr. Cornwell, our executive chairman, he published a white paper years ago that's been updated now. He talks about several drivers in home-based care, changing demographics, aging, the fiscal crisis of Medicare, change with the advancement in technology, and the whole COVID phenomenon, and the opportunity that we had and having to reimagine how we can deliver care outside of the brick and mortar hospitals. Patient didn't want to go there, right? Remember that? It's 3 years ago. I can't imagine, more than 3 years ago, where everything shut down, nobody wanted to go, we all huddled inside a house. That really was an opportunity. It really highlighted, it really supercharged the whole idea of house calls. COVID was horrible, don't get me wrong, but it really gave us the opportunity to shine in terms of what we can do for our patients at the location that they prefer. Aging demographics, none of this is going to be new news to you guys. 20% of the population will be over the age of 65 soon, and that's 40 million additional Medicare age patients. And you know, we all know Medicare is in trouble. You can look at different people's projection on when it's going to run out of money or be in the negative territory. The surge, or the number of people coming in into the 65 years or older are from, well, at least two, possibly more. One is that we're living longer because of changes in advancement in medicine and so forth. Also the baby boomers that are aging into this particular group. When I was at a patient's house yesterday, they had the Golden Girls on. Am I dating myself? Right? They had the gold. So not all golden years are golden girls, right? This is what we see. Not everybody age well. And those with complex illnesses, as they age with added complexity, the top 5% consumes over 50% of total Medicare dollars, and the top 1% uses nearly 80%. This is where we are targeting our work. We have an incredible opportunity to bend this cost curve here. Healthcare reform, again, not news to you guys, going away from fee-for-service. I was listening to a podcast on a way up here. Again, it's about value-based care, about hospitals, providers taking on contracts with up and, in the future, downside risk, right? It's no longer a transactional kind of approach to medicine. It is now, yes, you do your medicine, you better do it well, you better demonstrate quality, because we're going to dangle the carrot here, and we might take your carrot away. Actually, we might ask for you to give me carrots if you don't do it well, right? And models, and I'll talk about just 2 studies, there are more. Models of home-based medical care have shown to be effective and cost-saving. And I already talked about the issue with Medicare that many of us are aware and concerned about. This is a study published in JAGS in 2014 by Dr. Eads. I met him at the American Geriatric Society in Long Beach about a month ago. He published this study way back when. And if you look at just the top line, you can say, oh my goodness, look at how much more money the VA is spending with the implement of house call medicine. You spent 460% more. But wait, if you go all the way down, take out nursing home, hospital, outpatient, adds up to nearly $9,000 savings per veteran when they had home-based primary care. Right? Just think about that for a minute. That's a lot of money. Baby boomers, aging, 40 million, do the math. The Independence at Home Medicare demonstration, arguably the most successful primary care demo that CM has operated, okay? They looked at patients with chronic conditions, ADL deficiencies, hospitalizations, and this is the cost or the savings that was split between practices and Medicare. And they were looking for experienced practices and who had 200 or more patients. Year 7, that was just released in, I do believe it was in JAGS. Look at the savings per beneficiary per year. Again, that's a lot of money when you multiply by how many, not veterans, how many Medicare beneficiaries who can really use this type of care. Again, it's what they want, what they need, good quality, and saving money. What about a palliative care program? All right, does that make an impact? This was a study from 2017 looking at palliative medicine and their impact on the ACO. Cost of care, last 3 months. And I'll talk about the last 3 months data later on in the slide deck. Reduce the last 3 months. Part A cost is down by over a third. Part B cost down by a third. Hospital admissions down by a third in final months. Hospice admission is up, and the length of stay on hospice increased a lot. So as providers, we ourselves need to clarify our lane, and we need to tell our, like 3 hours ago, I was in the living room talking with a patient. What's the difference between what you do? What is palliative care?
It's huge.
And how's that different from hospice? Okay, your elevator speech has got to be ready for those. You can't sit there and then draw things, with your toes in the sand. You've got to be polished and ready, because if we're going to advocate for better payment, better service, and whatnot, you need to know exactly what you're doing, how you're doing. What you're doing is similar and different from a palliative care service, and also what a hospice service provides. And be ready to dispel the typical urban legend of hospice care. be comfortable with the M word, as I say, morphine. All right? Right? Be comfortable with the H word, hospice. Okay? Because people come with different ideas. They just give grandma morphine and let grandma die. We've all heard that. Okay? Be ready to dispel some of the misconceptions that people have. So demographics is pushing this. Technology, we all have, smartphones, and we can do EKGs at home. You can do point of care testing, discussion apps to help with decision making, whether you use Hippocrates or MedCalc or Medscape or whatever. X-rays can be done at home. We don't have an iStat machine. That's what it is in the right upper corner there. We do blood draws, blood testing the traditional way. We draw blood and we centrifuge. We spin the blood down in the car and we send it off for processing overnight. So there's technology at home. And Melissa and I don't know if Dana was there too, we were in Dallas showing our learners how to use a point of care ultrasound, it's called POCUS, how that can help us with diagnosis and treatment of our patients, in particular heart and lung related conditions, right? You can use POCUS to see if you have fluid in the lungs, curly B, curly C lines. You can look at JVDs so much better than, I don't know, I'll confess, I have a hard time doing JVDs at the bedside. I don't know about you, right? But POCUS can be a huge aid in terms of helping us making that accurate diagnosis. Does the patient need more diuretics or not? Is the shortness of breath from volume overload, or maybe it's more COPD related? So technology is there to help us. And then the COVID pandemic, I talked about it already. Using telehealth, seeing the patients, again, like what I said before, they didn't want to, many of them still don't want to go to the hospital, the emergency room. They want to be treated, diagnosed, taken care of at home, whether it's a face-to-face visit or by telehealth. For us, we used telehealth when the COVID first hit. We did telemedicine for about a month. And then we went back to face-to-face, all geared up and ready for work. Because telehealth, telemedicine for us in our patient population, it was I think it was a good supplement for the care that we delivered, but it was not a substitute because of their complexity of the symptoms and the conditions that they have. I wish I could show you the picture. 2 days ago, I did a telemedicine visit with a patient for follow-up after her fall. She's a long-time patient. She was 95. So we did a telemedicine visit. She had one of those birthday glasses on, really like an Elton John kind of thing. It was really thick rim, and it said "Happy Birthday" on top. And she was so happy. She went out for the first time in like a year to celebrate her birthday. But then that's when she fell. The challenge with that video visit was all I could see was like nose up, all right? And then, she was laughing and giggling. I just, can you turn the phone down a little bit so I can see your knee, and your ankle? And it was like, how do you do that? How do you do that? So telemedicine was, and it still is, helpful to a certain degree, but, I only got to see her forehead for the most of the visit, but not the knee and the ankle, which I was more interested in. Improving access to medical care and reducing barriers, especially when they don't want to come into the hospital. We can go out to them. They're happy. They want to be home. They don't want to be in a room waiting with 10 other people who's got COVID, cough. Para-influenza is going around here in our community. A couple weeks ago, it was the regular influenza and the human metapneumovirus. You get the idea. They want to be home. They want to be discharged to their living room, right? Not to a facility. Home is better. right. The other key ingredient is I'm talking about this incredible need, is that we need workers. We need people to do this kind of work, whether you're talking about home-based primary care or home-based palliative care. We need workers. And this is just a demonstration of providers making house calls and what we call high volume providers that are making 1,000 visits or more annually. So from 2013 to today, we've grown from 500 thereabouts to about 3,000 plus. Is that good? How many more do we need? We need that many more. Okay. 85% of patients who are homebound or home limited, they are not able to access our care. If that was cancer care, orthopedic care, heart failure care, nobody would accept that. No one. Okay. And there are a couple of states, I think it's South Dakota, Vermont, and Alaska. They don't have anybody. HCCI, we are here, we are all here to change this number, to make it better for our patients, for your neighbors, for people you know who really need this kind of care. People ask me what are some of the characteristics of a successful house call provider. These are my 8 C's, and they are competent with complexity. Our patients are complex. All right, we did a study of our patients, the number of medical conditions, no, the number of medications my patients took from our study, 17. Their problem lists, they're huge. You know that. You have to be able to swim in that and be comfortable with it. You have to be able to communicate comprehensively. I already talked about that a little bit, being able to talk about hospice and palliative care, talk with the patient, talk to the caregiver, talk to the home health agency, talk to the hospice director, and so on. Be able to communicate with different people at different levels, professionally and also at a personal level with patients and families, okay? The other is character and composure. Character, I'm a guest in your house. Character is a non-negotiable, right? Composure is when you step into the home and you're not quite sure where to put your bag or anything, and you're not quite sure what you're stepping on. On top of the complexity, you have to have this inner strength to do the work that you've been called to do, right? Charm and charisma, charm in a winsome way, because you are going to be talking with patients and families about some very serious things. And you need to be able to lead and guide them in a winsome fashion. And then the charisma to lead them through, like, I'm going to walk with you through, like the patient I saw 3 hours ago, I'm going to walk with you and the caregiver through your cancer. We're going to be there together. That energy, that determination that I'm going to go and stick with you. And that also goes with your practice. We're going through a lot of changes, even in my practice, whether we're talking about fee-for-service, trying to hire people, trying to make sure they don't leave, right? Okay? You need that charisma to lead. Lead your patients and lead your practice, obviously with different lenses, if you want to call it that. Many of us are mission-driven people. We hear that calling to serve. I've been blessed to have been given this opportunity by the good Lord to do what I'm doing. And I'm here to take care of these patients with serious illnesses. You can see them, the stuff we talked about, medication list, complex medical conditions. How many of you, when you check your blood test tomorrow morning for the results, I think they're all abnormal tomorrow. They're all going to be red, right? Nobody's in the normal range, or seldom. Be able to navigate how do you manage this and that condition when all the labs are abnormal and so on. Psychosocial complications, challenging family dynamics. Yesterday, I was with a patient's son and the patient. Patient has advanced dementia, but she's actually still able to argue and articulate and so on. The pressure point came to be that this patient is currently at an assisted living facility. She wants out. She's miserable. She's getting more and more depressed every day. I need you and my son to come up with a plan to get me out of here. The son has already tried 24-hour caregiver at home. That was a crash and burn. How are we going to solve this problem? How does primary care, how does palliative care come in to do the full service thing that we talked about, which we will talk about a little bit more later on? How do you deliver the care for this to the patient and take care of the son and carve a way out of this very vexing problem? Again, this is kind of different way of looking at the 8 C's. You got to have good clinical skills. Remember, you just can't consult somebody, right? You're the main. No, often you're the only provider at the home. There's not a cardiologist that's going to come in behind, or a pulmonologist. You have to have good knowledge, reasoning skills, competent in assessment and diagnosis, and being able to do procedures at home. And we do procedures at home at HCCI. I have courses on how to, I'm going to be doing a tracheostomy change in a few weeks. We do that at home, yes. G-tube change, yes. Knee injections, we do that, and there are courses that's offered at HCCI, so feel free to check those out. Integrity, safe and quality care. You have, how do I put this? Confidently cavalier. You have to be independent, but you are able to test in a confident way the care plan that you're recommending for your patients, okay? Keen attention to time management. We talked about that, whether you're on the fee-for-service or value-based care. You're out there, we talk about windshield time, how much is a reasonable, what's a reasonable time frame for a follow-up visit, for a new patient visit, and so on. Time management and organizational skills, very important. Obviously, written and verbal communication skills, which we talked about before. I might add good computer skills, right? We're all on EHR. How can you be efficient with a clunky name your EHR system? What members compose of a primary care team? Now, for me, we end at bullet point 4. Remember, I'm under fee-for-service. They don't generate revenue under fee-for-service for the most part, okay? So I have to pay for them. And that adds to overhead. Under value-based care, it may be different. You're going to be paid per member per month. You have extra dollars to hire a part-time pharmacist, for example. Okay, for me, under fee-for-service, we are operating with a top 4. Yes, I would love to have a social worker. I did a random poll with my nurses. I asked them, how many of the medical questions that you get on over the phone line, how many are truly medical? How many are social? Over 50%, 60-40, social versus medical. That was a random poll, just asking my nurses, gut feeling. Palliative care team, I was talking about, and the CAPC, that's Center to Advance Palliative Care, CAPC. They actually published a study on the landscape of home-based palliative care. And You can see the staffing is a little bit different with the palliative medicine side, with emphasis on social work and chaplaincy, almost a little bit like a hospice model, if you will. So that you can see, compared to a home-based primary care team, it's a little bit different in terms of perhaps the focus of what we do. I have the study here from CAPC. They looked at the home-based palliative care services, and it was interesting. There are a lot of good highlights with the study. 44% of the palliative service at home, patients stayed with palliative medicine only. 31% graduated to hospice. Meaning what? If you're on the palliative medicine, you're sticking with your patients, and they're going to have the same kind of issues that I'm dealing with. Pain, shortness of breath, depression, leg swelling, you get the idea. So 44% of the patients remained on palliative care. There's a lot of similarity or synergy in terms of what we can do, separately, but imagine what we can do together. So when we bring the residents here, what do we base our teaching on? This is the 4M. You can read about where the 4 M's came from, and then the final 5th M, which I will talk about here in a little bit. The 4 M's is a framework. The first is what matters most. It's about goals of care. It's about delivering the care that's consistent with what the patients want. Finding out what they want, setting goals, how realistic are those goals, completing the advanced care planning. How do you communicate this with all their kids, the hospital, and so on, and updating the preferences when they might have been full code, but after the 4th CHF exacerbation, hospitalization, and now back home, they may have changed their mind. Okay, so it's important to find out what matters most, because I tell my patients, if I don't know where I'm going, I don't know how to get there. Okay, or you can say any path will get you there. Mentation, it's about engaging the mind. COVID was so tough for our seniors, right? When we lock them up, I can't believe we did that. Isolated them. No contact, or through a plexiglass or through a window or something. I personally think that was just a terrible thing we did to our seniors. And from that, we know that the isolation can be very damaging and so on for their well-being mentally and socially. So we need to pay attention to what can we do to engage their mind, what can we do to prevent delirium, or to treat their agitation and combativeness. We deal with patients with dementia, and sometimes they can get a little challenging, right? We've all been there, dealt with those patients. Okay, there's not an easy path for those patients, but what can we do in terms of maybe medication change or having activities for them that can keep them out of harm's way. Mobility, again, that's a huge benefit for us. I do what's called a walkthrough when I do house call visit. Show me, like this patient that I saw today, a different patient with multiple sclerosis. Where do you sleep? Right here in the recliner. Okay, how do you get from here to there? And the wife demonstrated this really interesting gizmo that they bought on whatever, Walmart, Amazon. I've never seen it. In 23 years I've been doing this, like that is, so I got a picture of that. Mobility, what are the barriers that they have at home? Do they have grab bars? Do they have toilet seats, risers? Do they have a stair lift? How do you get up to the first floor? How do you get out of this house? Okay, so mobility. Use the advantage of being at the home. We have an opportunity to do things, to see things that no other office clinicians can possibly experience. That's a huge advantage, huge win for us, more importantly for our patients. Lastly, medications. I already talked about 17 medications. That's ridiculous, right? How can we de-escalate, de-prescribe? In our courses, Melissa's Essential Elements or Advanced, we talk about polypharmacy and de-prescribing. There's a course that you can visit on how to do that, and some of the apps that you can use to help optimizing medications at a geriatric-friendly dosing, whether you're talking about apixaban or Eliquis, dose at a kidney function, or even like antibiotics, cephalexin or Keflex, at a geriatric-friendly dosing. Use the opportunity to review the medications. Again, when you're at the home, you have such a unique opportunity, right? So when you're at the office, the assistant will turn the screen to you. These are your meds. Are you taking them? What's the answer? Uh-huh. All right. So somebody once said, not many guarantees in life, death and taxes, and the medication listed in Epic is wrong. Okay? So you have the opportunity to say, what's in that bag? Is that everything? What are those in the back? You have the opportunity to see and clarify everything. All right? Where are these medicines that's on my list? Oh, those are my night medicines. They're in the bedroom. They're not in the kitchen. Okay? And then show me how to use your inhaler. How many of them, you see, I saw a patient in the airport before getting on a plane. It's 2 squirts of their inhalers. 1, 2. Is that going to work? Do they need another inhaler? Do they need another LAMA combination drug for their COPD? They just need to be taught on how to use their inhaler correctly rather than the 1, 2, and then I'm boarding the plane. Right? You get to, show me. I talk about medication reconciliation, justification, justify why you're using this medication, optimization, optimize for liver, kidney function, and so on. And the last is demonstration. Show me how you shoot the insulin. Show me how you use your inhaler. Show me where this is, okay? So you have an opportunity to do that at home. And then walk with your patients. When you de-prescribe, they get very fearful. They're very attached to their vitamins. You're taking my multivitamin away. Walk with them. I'm not abandoning you. We'll walk through this together. If there are any changes from de-escalating these pills, I'll be right here with you. And if you have the money, you can have a pharmacist work with these patients. I'm de-prescribing 17 pills. MultiComplexity is putting it all together, right? Help them manage multiple conditions. Assess the living conditions, which we talked about, optimizing therapy, getting other people involved. I'm only a doctor, I tell my patients. All right, I need therapists, I need psychologists, I need nurses to come in and help me and coordinate everything and integrate into the care plan for your patients, talking to them about their goals and also talking about the risk and benefits of, say, adding another medicine and what might be involved in terms of, say, blood testing and so forth. This is putting MultiComplexity into action. You plan, you do. You don't say goodbye, you check, and you go back and adjust. The common scenario would be somebody with CHF, you add more diuretics, you reassess the patient, you check, now the BUN and creatinine is this and that. I might need to back down on the water pill. Okay, putting, again, in the whole context of what the patient is like. I'm going to introduce a patient to you all. And in a little bit, I want us to just, at our tables, talk about how we can meet, care for Christina and Veronica. All right? Let me just talk about Christina. She lived in Romania until 3 years ago. Her daughter came to the States on her own. 3 years ago, Christina became ill. And Veronica said, Mom, you're coming over. Brought her over to the US. Diagnosed with stage 3 cancer. Ovarian cancer, debulking surgery was done, underwent chemotherapy for about 6 months. She continued to live in the States, and with Veronica, her daughter, since the diagnosis, and she'd been doing okay, but her tumor marker started to go up, and she was in the hospital a few weeks ago for another surgery due to bowel obstruction caused by adhesions likely related to her first surgery. This is just kind of a summary. She's getting weak. You're seeing her now, pretending you're making a house call, seeing Christina and Veronica. Weak, fatigue after the hospital. Language translator, since patient only speaks Romanian. You can take a look at her past history there. Going down to family and social history, I want to note that immunization it's no, 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 and no. Okay, home-based primary care. What can we do to intervene here, right? Surgery history, family history. We provide primary care, multiple disease management. We're available 24/7. If you look at the CAPC study, not all palliative service at home are available 24/7. We do post-hospital acute care, transitional care medicine. Like Christina, we do preventative care, like immunizations that she needs. If she had a need of wound management, we do wound care, right? And we coordinate with other ancillary services, and in terms of laboratory testing, if she's anemic, her kidneys, this and that, we can arrange for those procedures to be done at home. What about palliative care? If you are, say, looking at Christina from more of a palliative lens, what do palliative medicines do? You can exist in a hospital, obviously outpatient nursing home, and as the CAPC studies show that there are more palliative medicine being at the home. We take care of patients there with refractory pain or other serious illness symptoms. Talk about complex family issues. We focus on financial and non-medical needs. And again, we provide through palliative medicine, psychosocial, spiritual support through a interdisciplinary team. So there's some similarities with home-based primary and home-based palliative, but there are these intersection in the middle where we do a lot of this similar things. We support the family and the caregiver. We do social, spiritual support. We do care coordination. We do symptom management. Prognosis support. Patients often want to talk to us about, how long does grandma have, right? Interdisciplinary team meeting. We do refer patients to hospice even without, say, going to the next step of palliative medicine per se, which I'll talk about that in a little bit. And we do talk about advanced care planning and end-of-life discussions. So both from a palliative and a primary side, we do some of the same things, but then like the other circles, there are certain strengths related to more home-based primary care versus a palliative care approach. So what is the full service? That's what we're talking, that's why we're here. We're looking for a full service solution for Christina. So Veronica, what are her hopes? She's the daughter. She's the power of attorney. She hopes for Christina to have more energy. Remember, she's really tired and weak. She wants to maybe restart chemotherapy because the level is not going down. If anything, is going up. Veronica, the social side, she needs to go back to work. She used all of her FMLA. Yeah, but she needs health insurance. How do you help Christina by helping Veronica? Remember, I talk about it's a dyad. It's always the patient and the caregiver. And I said it to my patients today when I was making, I need you, the caregiver, to be well. Because we work as a team. If you go down, mom's going to suffer. Okay, I have to take care of you indirectly because it's really a team approach. Somebody brought up social determinants of health, and these are some of the concerns. Patient depends on Veronica to get the medications. Patient only speaks Romanian. Patient is dependent on daughter's income, but she's not been able to care for the patient, and she's feeling really exhausted from caring for mom. And it's become increasingly difficult to get patients out of the home because of her increasing weakness. How can we come together to take care of Christina and Veronica? Looking at a full service solution. There are the ADLs. She's unsteady. Everything is slow. I talked about the walkthrough. There are throw rugs in the hallway, no grab bars in the bathroom. There are no benches. Some DMEs that you notice when you walk through the house. You got a walker and a wheelchair. Orthodox faith, and is very important to her. And then we talked about using an instrument to test for caregiver burden. That's the common one that we use. You can see that she's mildly to moderately burdened from caring for mom. So at your table, talk about what does home-based primary care bring? What does a palliative service bring for Christina and Veronica? Okay. Are there other types of patients who may benefit from receiving both? And how may this full service solution for our sick and complex patients impact providers and other members of the care team? I'm going to leave this slide up there. I encourage you to discuss at your table, jot down some ideas. Applying this complex, this full service model in managing in our patients. It gives us the opportunity, primary, palliative, to serve additional patients. There may be additional revenue opportunities through, say, CCM or TCM visits. And if you want to know more about we have Super Bill at HCCI that talks about all the RVUs and the reimbursement and so on. How much do I get for CCM or TCM and so on? It's there. So again, visit our website. We, with the combined model, if you will, we can fully meet the needs of patients and their caregivers by coordinating medical services with maybe different perspective on the same patients. Focusing on what matters most to our patients, managing their symptoms, one of the S's, supporting the caregivers, advanced care planning, having that difficult conversation with Christina and Veronica down the road, right? Sounds like her tumor's coming back. And the daughter wants full court press. At some point, we're going to have that one serious or multiple serious conversations with the patient and the daughter. And then appropriate timely referral to hospice services. Again, we don't want, and we've all heard the story, right? Mom was on hospice for 3 days and died. Too bad. Hospice is great. Hospice provides great services. People have been paying into hospice under their Medicare Part A payment, right? And they only use it for 3 days when they have such amazing support with people, with medications and the equipment. That could be this package of supporting the patient and their caregivers at the end of life. Remember the elevator speech, you have to be ready, the difference between primary care, palliative care, and hospice care, right? You could develop, and I encourage all of you to have that elevator speech ready. Okay, you don't hesitate when a common question like this comes up. For example, two of the difference between palliative and hospice care, one could be the focus, if you will. Under palliative care, you can still focus on curative treatment, right? Whereas hospice is more on symptom management, even more. And the other will be timing. Whereas palliative care can come in any time during a person's serious illness diagnosis, whereas hospice by Medicare definition, it's the last 6 months, right? So it's timing and focused. So one of the slides talks about, in terms of model, you can have co-service model, like you can have a palliative care APN and a primary care APN coming in and taking care of the patient, all right? That's one model. The other model, which is our practice, is that one provider we do it all. We do primary care, and we're all very well versed in hospice and palliative management. And so there are different models that you can think about. If you're a primary care service, can you graduate and do some of the palliative care on your own? If you're a palliative care service, do you want to network with a primary care service, or maybe you can branch and develop your own clinicians to do primary care at home? So there are just different ways for you to kind of imagine your work. I'll finish with this. Remember, they talked about reducing, under the palliative care slide that was published in 2017, about the last 3 months of care. Those are costly months for our patients. They're in the hospital a lot, and they're in the ED a lot, and they're in the ICU a lot. If you look at the national data that's up on top, ICU stay 30 days before death, 29%. Hospitalizations, 3 months before they passed, 69%. Come down here to my practice. Look at the difference. Okay, where do patients want to pass away? Here? No, they want to be home. We're delivering the care that's consistent with their wish without sacrificing quality at a fraction of the cost. Elevator speech, be ready. What's your value proposition? This is just one of them.